So a very good evening. So now we will continue the part second of Torticollis. So here we are going to discuss about the secondary effects of the Torticollis. So we have already divided it into two age groups. So one is the infants and the second is older children. So in infants you will see that there will be two things which can occur. The one is plagiocephaly and the second is hemifacial hypoplasia. So plagiocephaly, if you see in small infants with torticollis and the fixed rotation of the head, the gravity deforms the relatively soft head as it lies in the same position for a prolonged period. So flattening of one occiput lead to secondary flattening of the contralateral forehead, and this asymmetric skull deformity will be called as plagiocephaly, and it develops in the first few months of the life. And if you speak about to observe it, it will be better observed from the above the head. Once the child begins to sit up for the or the torticollis resolve, the plagiocephaly will simultaneously tends to resolve as well. So it may take several years to disappear, and a few children have a slight permanent deformity. Then we talk about hemifacial hypoplasia. So progressive facial deformity is seen when sternocleidomastoid muscle is immobilizes the face for a longer time. So there is a rule in pediatric that uh, the normal growth of the bone depends on the normal muscular movement. So because of the torticollis, there is a restriction on that particular side, and there will be growth hampered on the same side. So that will cause hemifacial hypoplasia. So degree of hypoplasia of one side of the face can be determined by the angle. Usually in normal people, this angle, the plane of the eyes and the plane of the mouth, this angle will be parallel. This plane will be parallel. But because of the hemifacial hypoplasia, uh, there will be a angle formation, and it will cause asymmetry. Okay. So significant hemifacial hypoplasia takes about 8 months to develop, and but it is more often recognized at about 3 to 4 years of age, and it becomes less obvious with ongoing growth once the torticollis has resolved. So if we talk about older children will have, as we have discussed in the part first also, that there will be a similar side shoulder upliftment, and along with this there will be a compensatory cervical and thoracic scoliosis. So this is basically a postural compensation. So now we are going to talk about brief about the management. So first comes the conservative management, because majority of these children, this thing resolve on its own or with the help of conservative management. A very few percentage of children will require surgery. So spontaneous resolution in majority, in rare children will require surgery, as we have discussed in the part first also. If you talk about the manipulation part, so value of manipulation has not been proven in the studies or in the literature. So physiotherapy and regular neck exercise appear to be safe and may make the parents feel that something has been done for their children. And then physiotherapy, and then the role of intensive passive neck range of the motion stretching exercise. So it is debatable whether whether there is a role or not. And there are equivalent of the evidence. Then the literature say encourage parents to keep toys or items on the ipsilateral side so that child will move his or her neck. And if we talk about the reassurance is something which is required. So the passage of time is probably as effective as the various manipulation that has been described in the literature when torticollis is due to sternocleidomastoid fibrosis. Okay, so that you have to remember. Then the botulinum toxin can be helpful. Then if we talk about indication of surgery, so indication of surgery, you have to remember just 3 indications. The first is persistent sternocleidomastoid tightness, which is limiting head rotation and beyond the age of 12 to 15 months. Okay. Then the persistent sternocleidomastoid tightness with progressive hemifacial hypoplasia that I have already described, and if the diagnosis in children is made after 1 year of age. So these 3 you have to remember. Okay, so there are only 3 indications. Okay, this one, and this one. So if we talk about operative technique, I'm not going to discuss the entire operative technique in detail. So it's usually done in under general anesthesia with laryngeal endotracheal intubation, supine position with shoulder elevated and neck will be on the contralateral side. So the main idea is to divide the muscle. Sorry, the main idea is to divide the muscle. Then so the better or the more evidence is in the form of when it is divided at lower end, both the cervical and both the sternal and the clavicular ends. And there are equivalent papers or literature which says that the upper end, both ends or even at middle can be done, but the good results are with the lower end. And one has to remember, along with the division of the both the heads of the sternocleidomastoid, one has to divide the cervical fascia also, because if it is not divided, it may lead to recurrent torticollis, which can be seen in less than 3% of the children. So the endoscopic tenotomy, that is TTESR, totally trans endoscopic surgical release, has been described. So the open surgeries or the which I have just discussed, it can be done as a day case. No post-op restriction of movement is needed, and full range of neck is usually achieved by 1 week of age in the infants or the early age group of the children. Older children may take time. So if we talk about post-op physiotherapy, it is usually not needed or unnecessary, but people tend to advise to these children. And if we talk about complications, so complication can occur in the form of hematoma, because there is like superficial veins can be there, and one need to take care of all those things. And the recurrent torticollis, if the cervical fascia is not divided, can be seen in less than 3% of children. If we talk about follow-up, so there are 3 to 4 things that you have to remember, that until torticollis has resolved completely and there is a full range of movement of the head and neck, as we have already described, it takes around 1 week in the younger children or in the infants. And SCM, that is sternocleidomastoid muscle, feels normal. And in older children where there is a secondary scoliosis, follow up should be done, including the radiological studies wherever it is required, and it should continue till the complete resolution. So that is all about the second part. So thank you very much for a patient listening. I'll come with the third part where we'll discuss a clinical case. Thank you so much.